Good morning, good afternoon, or good evening to everyone. I'm pleased that we are finally able to host you in person after more than 2 years of COVID. It is wonderful to see our board of directors, advisory board, commercial partners, and capital market representative here with us, representing so many different parts of the globe, including the US, the UK, Korea, Europe, Ghana, and Morocco. We are all gathered here at the Nanox headquarters in Neve Ilan, accompanied, of course, by those of you who have joined us online. We would like to take this opportunity to share insights into our Nanox ecosystem, our future vision, and expected development. We have a lot in store for you today, so let's begin. I would like to invite our first speaker, Dr. Orit Wimpfheimer, Nanox Chief Medical Officer, to share with us the Nanox Medical vision. This is the foundation that drives the Nanox technology and business model to improve patient healthcare.
Hello, everyone, and welcome. I'd like to take a few moments to share with you the Nanox Medical vision. Ultimately, we all want to do this to be together for better health. We'd like to significantly improve patient health care, and there's a real need. There's an exponential increase in the amount of money being spent on medical imaging. Just since I finished training over 20 years ago, the amount of money being spent in the medical imaging market has grown astronomically, with expectations to increase over $56 billion just in 2028, according to Forbes Business Insight. Much of that is in the world of X-ray imaging. Another expectation is that artificial intelligence will really take the lead to improve medical health care worldwide, and there's a lot of money and a lot of companies working on artificial intelligence solutions worldwide. However, despite all the money that's being spent, there are several key limitations within medical imaging. These limitations I live on a day-to-day basis as a radiologist, and I see them firsthand. The accessibility of medical imaging is really not equal for all. There are not X-ray machines or CT machines throughout the world in an equal manner. Not everybody has accessibility to the medical imaging that they need. And even in those places where there is accessibility, it's often unaffordable. Not everyone could afford to get their X-ray. Not everyone could afford to get their advanced medical imaging. Furthermore, there's a severe shortage of radiologists worldwide, and the population is growing older. According to the World Health Organization, by 2050, 20% of the entire world will be over the age of 60. Older people require more imaging with more chronic conditions that require medical imaging in order to improve patient health care. In the US alone, between 2010 and 2020, the number of people over age 65 increased from 15 to 34%. That's a lot more older people that require imaging. And yet in the same time frame, the number of radiologists that have finished medical training has only increased by 2.5%. There isn't the ability of radiologists to keep up with the amount of imaging that's going to be needed worldwide. And furthermore, there are severe health inequities that are partially due to medical imaging, as not everyone has the same equal opportunity to image their conditions in order to get the care that they need. Ultimately, there is very ineffective digital integration. You can go to an imaging center and your images are stuck at that imaging center. You can go to a physician and they have no access to your imaging, and you're left kind of pondering how to deal with this situation. And as a result, there's often delayed diagnosis, both for acute and chronic medical conditions. The COVID pandemic really highlighted these medical health inequities worldwide. There's a lot being written on. There was a radiology article just this past year how medical imaging health inequities are really a long list of problems where people do not have access to the imaging they need, and we really saw a very big difference in the outcomes of COVID patients because of this factor. Ultimately, at the end of the day, the patients are stuck. They need to take a more active role in their healthcare, and they have no ability to do so. What Nanox would like to do is really turn this paradigm around and bring an end-to-end solution for medical imaging with multiple key elements all put together under the Nanox company and brand in order to improve medical imaging and really deal with many of these key limitations. We'd like easily implemented device, of which the Nanox ARC you'll hear much about in a later presentation, but many devices that could all come together to make imaging accessible and affordable. And one of the key factors is have a technologically superior source for X-ray technology that makes the imaging more affordable, easier to use with less disruptive technical difficulties, and really be able to put this throughout the world. Using artificial intelligence algorithms, we can help facilitate evaluation of all these images we hope to create, and having a marketplace and a teleradiology embedded within the Nanox family will be able to really deal with images that are created. The business model of a pay-per-scan is meant to make imaging more affordable per patient, so a patient could actually afford the imaging that they need. Ultimately, we need to integrate this all digitally to make patients more able to take control of their own health care. So when you look at the end-to-end solution within the Nanox family, you see the Nanox ARC as our first medical imaging modality, which you'll hear more about, with the expectation of adding additional devices that could be implemented cost-effectively throughout the world. Ultimately, that data will be presented onto our marketplace on a cloud-based technology so that all the data is available on the cloud and stored properly, facilitating the ability of using artificial intelligence to maximize the diagnostics on those images, enabling teleradiology such as USARAD to facilitate the diagnostic reporting. We're also going to use artificial intelligence in another sphere. So AI, in my mind, is the key to the future of managing with so much data for medical imaging. And we have two different foci for artificial intelligence. The first is facilitating diagnostic throughput. So you have radiologists who have so many images. In fact, currently now in many countries, radiologists themselves don't read the x-rays. They just don't have time. The x-rays get read by other clinicians or never get read at all. We'd like to change that paradigm using artificial intelligence to differentiate between normal and abnormal scans and really highlighting the abnormal findings within the images themselves, facilitating diagnostic quality, accuracy, and efficiency. In addition, we're using artificial intelligence to maximize the data already created on CT scans performed anyways for any reason at all, really empowering the data to get the most out of the data that's created anyways, to really identify chronic medical conditions on patients, to treat them, identify them in a much earlier fashion, and thereby we'll be able to go from predictive to preventive medicine and really decrease the health inequities out there in the world, improving patient care in a financially viable alternative, with hopefully to make a real impact on chronic diseases. Our vision for the future is really to empower the patient. In order to do that, we need to have the right digital integration of all of our modalities onto the single platform using cloud-based technology and scalability of data, using artificial intelligence, and really enable the patient to have the ability to have everything on their own personal device. Wouldn't you want to have your medical file and your medical images on your personal device so that you can control what happens next and where you go? Currently, patients can't do that. If at best they're walking around with a CD of a study that they had from somewhere and they have to figure out where to go next. If we integrate it all, if we make patients capable of taking control of their own health care, we hope to make a big dent in the future of medicine. Thank you.
Thank you, Orit. I now ask Ofir Koren, the Nanox ARC Division General Manager, to take you through a live demonstration of the Nanox ARC with full radiation with an X-ray room. You will see the Nanox ARC ecosystem, its workflow from the Nanox ARC scan uploading to the Nanox.CLOUD to the marketplace.
Thank you, Erez. Well, seeing is believing. What I would like to do today is to take you to a short journey that will split to three. The first one would be to go into the X-ray room. Let's go there. The second phase would be a live demo. And the third phase would be covering the data flow of the ARC and the marketplace and the cloud. So let's go to the X-ray room. So now you can see the ARC in the X-ray room. This is a regular X-ray room containing an ARC. The main components of the ARC is that one. This is a tank residing and including 5 cathode tubes, our own tubes. You can see here the cover of the tubes split into 5. And this is actually what creating the radiation. The second one is the bed. The bed actually moves and takes the patient to the right position in order to be projected as needed. And the third one is our tablet. This is where and how we control the system. Let's continue and to the second phase and do the live demo. So with me, this is Mr. Lidor, who will operate the system. Lidor, please take the tablet. So what we would like to do today is to demo you a projection. What you see now on the screen is the welcome new patient. You can see that we can do a scan patient QR code or to enter the details. We will now scan the QR code. Now you see the patient details getting into the system. You can see the patient name, last name, identification, and so forth. So now we confirm patient details and move forward. Now we can select the body region. When we select the body region, there is a protocol that download from the cloud. You can see here that we have a chest protocol 01. This is a 90 kV protocol. We selected a protocol and we will continue. Now, while we selected a protocol, the next phase would be to adjust the ROI. We take the patient to the right position and stop the system. The next phase would be to confirm the protocol. We will now select the patient position as supine and confirm the patient position. Now there is a phase before we activating radiation to verify patient identity. We have all the details now and we can confirm and move forward. We will wait for the green light to radiate. Lidor will push the irradiation button and the scan begin. You can see the system activating, taking images, 2D images that will formalize to a 3D images. This is obviously a live demo. The system ended, and now we are going to the phase of the reconstruction. This phase, by the way, will take us some time, so I would like to take you to the third phase of the presentation and show you the data flow. You can see here on the presentation that we have several components. There is the tablet that we already saw. There is the Nanox ARC, which is split to software and hardware. And we have the medical cloud and the operational cloud. And finally, the marketplace. Now you will see throughout my presentation a yellow spot. This yellow spot actually create or facilitate the data flow from place to place. Let's start. So this is the operator login. The operator log in, you see the spot here going from the tablet towards the software. The next phase would be the operator to enter patient details either manually or, as we said, with a QR code. You see the data go into the software itself. The next phase would be that the operator queries the protocol database. You see the spot going forward. In the operation cloud, for result matching or selected body part, the operator receives a list of protocols to select from. So you see the spot going forward and going back to the operator. Now we have a protocol. The operators select the protocol, the appropriate protocol, and then data is transferred toward the software. The next phase would be that the operator then proceeds to select the patient position. And while the patient position is selected, the camera transfers the data, and we can select the patient position. Once the operator confirms the desired positioning, the protocol, patient details, and any other required modification, a hardware recipe is written to the PLC. The PLC is the component that controls the ARC. The next phase would be the operator is prompted to press the irradiation button for the scan process. Here's the irradiation button, and when it's pressed, it's actually transferring data to the PLC. During the scan process, the PLC fires the Nanox cold cathode, our own cathode tubes, and signals the detector. You can see the spot going towards the tubes, and the next phase would be to collect data. Once the detector receives the triggers from the PLC, it sends the images to the hardware service, which saves them and updates the UI with the status of the scan. Once the scan is done, the pre-process service runs the image correction on a newly acquired image. You see the spot there. And then once the pre-process service completed, the image correction, all the telemetry of data is sent to the operation cloud. This is how we control the ARC. And data is sent also to the medical cloud. This is the medical scan data. The next phase is once the medical cloud validates the image and the study info, the reconstruction process begins. You can see that. The reconstruction is done in the medical cloud. Once this reconstruction, the process is completed, the cloud creates a preview version that the operator, and for the study, that the operator quickly review and decide if the patient can be released. Once the operator approves the image, the medical cloud forwards the study to the Nanox marketplace for distribution. Thank you very much. And the last thing that you are going to see is the image that was collected in the live demo. So you can see here the image that was collected, but this is not the best. The next thing would be the best. Thank you.
Thank you, Ofir. I would like to invite Dr. Nogah Shabshin from the Department of Radiology, Pennmedicine, Philadelphia, Haymack Medical Center, Clarit Health Services, Israel, and head of tomosynthesis in the ARC division. Nogah will share with us, for the first time ever, interpretation of human scans from the Nanox ARC that were taken earlier in our clinical sample study facility at Shamir Hospital. We have received a Helsinki permit to conduct clinical sample study in Israel using our multi-source Nanox ARC system. We anticipate that the results of this study will generate clinical sample images of multiple body organs during the fourth quarter of 2022.
Thank you, Erez. So you heard about the vision, and you've seen the live demo of the entire process of the scan. And now I'm very happy to share with you the first digital tomosynthesis images on patients. We're going to see, we already did 4 in-human studies, and I will show you 2 of those now. Obviously, these scans, you can already put the images. Obviously, these scans were not performed here. They were done at Shamir Medical Center because clinical patients are scanned at a medical facility according to the IRB protocol. So these are conventional radiographs of a hand, the ones that we're used to seeing. We want these to be as sharp as possible, all the structures sharp. On the other hand, when we look at tomosynthesis images, then we're going to see many blurred structures, many blurred bones. But let's focus on the sharp ones because we want to focus on the sharp ones. Just think of this 2D radiograph where all the soft tissues and the bones are superimposed on each other, and the tomosynthesis splits them to layers. Whatever is in the plane of the layer is going to be sharp, and all the rest are going to be blurred. And actually, it helps us focus, keep focused on those areas of interest. So let's look, for example, at these 2 bones. There are 2 bones here. One of them is called the triquetrum, and the other one is called the pisiform. They are superimposed on each other, and therefore, if there's a fracture here, this fracture can be missed. When we're looking at the tomosynthesis images, at that plane of the pisiform, this round bone, we see the pisiform sharp, but the triquetrum is totally blurred. So we can scroll through the pisiform from anterior to posterior, volar to dorsal, until we're positive, we're sure that we saw all the areas of the pisiform sharp. That's how we know we covered this bone. But we don't see the triquetrum. And then, now we don't see the pisiform anymore, but we do see the triquetrum very sharp. And let's look at the opposite scenario, in which, as you can see, these the bases of these metatarsal bones here are superimposed on each other because of the shape, metacarpal bones, because of the shape of these metacarpal bones. For example, a part of this bone is superimposed on a part of that bone. There is a line here that can simulate a fracture, although this is not a fracture. But when we will scroll through these images, the tomosynthesis images, we will be able to scroll through this area and see that actually this is just the margin of the 3rd metacarpal bone, and there is no fracture here. So it helps us also feel confident that there is no fracture there. And let's look at another example. Let's look at a foot now. So this is again, by the way, the wrist is a 63-year-old patient, and this patient weighs more than 100 kilos. And yet we got good quality And we'll continue with another patient, and this is a foot. So there are some structures. Look at this area of the foot. This is one bone, the cuneiform. The second bone is the middle cuneiform. And here there are several bones that are superimposed on each other, and it's very hard to define which is which. When we scroll through the tomosynthesis images, this is that medial bone that was easy to define. And now we're starting to get to this area where it's hard to define which bone is which. So for example, we can see the structure here of the cuneiform bones. This line here, this part of the joint here is much easier to see when we're looking at the tomosynthesis, and we can scroll back and forth until we're sure that we covered all the bones and all the joints. Look, for example, at this joint here. This is the fourth metatarsal, and this is the cuboid bone. This is the joint. If you'll try to find this joint here, you can see how so many bones are superimposed on it that it's much harder to evaluate. So in the last few minutes, I tried to show you some of the advantages of the tomosynthesis, some of the additional information that a tomosynthesis can provide as an agent to radiography. Thank you.
Thank you, Dr. Shabshin. Now I invite Michael Attias, head of our Radiology department. Michael will introduce us to what we call Radiology and briefly take us through the ARC and AI solutions development process through the synthetic data.
Ladies and gentlemen, I am honored to present the progress of the R&D process of the amazing Radiology team. We have seen earlier by Ofir the Nanox ecosystem from ARC through cloud, marketplace, and teleradiology. Now let's focus on the AI components within that ecosystem, the Radiology. We have already addressed the shortage of physical devices worldwide, but yet there is another challenge to tackle, which is the global shortage of radiologists. Our vision is to empower data to support the work overload for patient benefit. The way we intend of doing so is by tackling chest and extremities studies, so we can create tools that will assist radiologists to focus on the studies that needs the most attention. The way we do it will be by providing AI solutions. But when we talk about AI, it always starts with data. We know that an AI algorithm will only be good as the data used for training. When we talk about CT scans or X-rays, there is plenty of available data to start using. But when you talk about the ARC, we're still accumulating data, and that will take time. What do we need data for? First and foremost, for training. We need to train the algorithm. For every intended use, which is case-specific, we have to collect tremendous amounts of data containing that specific indication from variety and diversity of patients. Then we take a subset from that training data set, which we call a validation data set, which is data set to help us evaluate the quality of the algorithm throughout the training process and development process. And the third data set is the test data set. This is an independent data set that the algorithm has never seen before. When we talk about the clinical realm, it is divided to a clinical data set, which is internal, and also a clinical data set, which is for the regulatory bodies to show and prove the quality of the algorithm. This is an iterative process until we achieve the proper KPIs that we have to show for. Once the algorithm passes the relevant threshold, it is being deployed. Once it's deployed, we keep on generating more and more data to be able to construct and improve the next version of that algorithm. So when we're discussing the ARC, we have a challenge because, as discussed, we need a lot of diverse data, which is case-specific. What we want to do is we aim to shorten that development cycle. The current process of developing such an algorithm is to build the concept, to do the research, to plan and define. Then we need to get and accumulate that data, but we also need to tag that data so we can teach the algorithm what we want it to learn and identify. And only when we have that large amount of data, then we can train the algorithm, verify, validate, go through the regulatory process, and finally deploy and commercialize it. What we're trying to do is to start this process today. We want to start this process by using synthetic data and tag that synthetic data to progress the algorithm as much as we can with synthetic data. And then to take much lesser quantities of data accumulated from the ARC to fine-tune the algorithm to achieve the relevant metrics. But how can we do so if we don't have that data available? First and foremost, we're leveraging existing assets. Nanox AI, which is one of Nanox companies, has many quality assets in its possession. Great infrastructure and a lot of diverse data that we can leverage for our purpose of developing AI for the ARC. So what do? We're generating synthetic data from CT modalities to digital synthetic tomosynthesis modality, which we refer as DSTS. So this is how the process looks like. We start off with CTs. Could be axial or coronal views, doesn't matter. We take these studies and we take all the different layers of the CT studies, we combine them together to create a 3D volume, a digital form that represents the body that was scanned by the CT. We then take that three-dimensional digital volume, insert it into a digital simulator that simulates the architecture of the ARC, which has similar outputs as the ARC of 2D raw images. These raw images are being inserted to the actual algorithm, the reconstruction algorithm of the ARC, generating digital synthetic tomosynthesis. And this is the process of creating synthetic data. Now let's look at yet another example of a knee. We start off with a CT phantom of the knee. We run it through the process of the simulator. We create a digital synthetic tomosynthesis through our simulator. And on the right side, you can see static images of those, of the knee. But let's see a comparison. How is the digital form similar to the actual output of the ARC? So what we have done is we've taken a phantom, a chest phantom, scanned it with the ARC in the proper protocol, and this is how it looks like. We've taken that same phantom, scanned it in CT, and run it through the entire process mentioned earlier to create digital synthetic tomosynthesis. And you can see the quality of what we've achieved so far. Still work in progress, but you can see the quality of what we've achieved so far. This is something we can start working with to generate our algorithms. But yet we can do another thing. Leveraging the data set, the database of Nanox AI, we can take actual CT scans with actual pathologies. So we've taken a CT scan with pulmonary nodule and consolidation. You can see on the left side in an axial view. and you can see the same image in a coronal view. We have transformed those to digital synthetic tomosynthesis, and this is how it looks like. So you can see on the left side, the nodule, and on the right side, the consolidation. But yet we know that to train an algorithm, it's not enough to have data. You need tag data. And we know that the common practice nowadays is to tag CTs, X-rays, MRIs, but not tomosynthesis. So what we have done is we've leveraged existing assets, which is to take existing taggings of data sets. So you can see on the left side, a tag nodule on an axial CT. On the right side, you can see the same nodule on a coronal CT. And we've transferred that tagging to tomosynthesis. So now we have large quantities of diverse and tag data that we can leverage for our algorithms for the ARC. What we want to achieve with this project are two main components. The first one is we aim to reduce the time to market for the AI solutions for the Nanox ARC, and we can potentially assist with examining and developing new clinical applications for the Nanox ARC. Again, this is a work in progress, but I'm sure that the best is yet to come. Thank you very much.
Thank you, Michael. Now, I have the honor of inviting Dr. Pickhardt to the stage. Dr. Pickhardt, who has the inspiration for using CT scans for population health screening and remains at the academic forefront of this endeavor. Dr. Pickhardt will introduce his vision of opportunistic screening using CT scans.
Thank you. I'd like to switch gears a little and discuss how superpowering incidental CT image data that's present in all scans that we perform, but which have been largely ignored until now, but which now through AI algorithms, we can harness this valuable information which we've basically disregarded up until now. This is sometimes referred to as opportunistic CT screening, which is leveraging CT data unrelated to the clinical indication. For example, a patient may have abdominal pain, be scanned to rule out a kidney stone, appendicitis, diverticulitis, what have you. Regardless, we can use the information beyond the reason for the scan and really harness the ability through AI. It's really through a confluence of factors that this is now coming to a head. This is something I've been interested in for many years. But the objective and reproducible nature of CT allows it to be generalized and compared throughout the world on scanners going back decades by any protocol virtually. There are millions of scans performed each day, essentially throughout the world, and up to 100 million scans in the US alone of the abdomen and the chest. So a lot of opportunity there. But it's really, the most important thing are these automated AI solutions that now allow us to harness this information, as I'll show you. And this is really getting at adding value to what we're already doing. It's what we've been discarding can now be retrieved. And this is really heading towards precision medicine and personalized care. This just illustrates how CT volumes have increased over time. This has continued this trend, and this is really throughout the developed world has been the case. These are just two recent examples of review articles that cover this topic, but we've published over 100 papers looking in the last decade or so, looking at opportunistic screening and incidental findings and focused on this. And just to illustrate what I'm talking about, we can depict this many ways. But here are some of these body composition biomarkers. Specifically, we can detect, segment, and quantify intra-abdominal fat or visceral fat, muscle, bone mineral density, liver for fatty liver, for fibrosis, liver volume, organ volumes in general. look at vascular calcium of the aorta and also of the coronary arteries. And it turns out this is very valuable data. We can project this in many ways. We can superimpose these AI algorithms, which makes it easy for the radiologist to QA. And then here are examples, individual examples of the Nanox tools that are currently in place. On the left is the bone mineral density and fracture detection tool. So as we know, osteoporosis is a silent disease. So no matter why that patient was scanned, we may be able to pick up incidental disease, specifically osteoporosis, sometimes complicated by fracture. And then on the right, we see coronary artery calcification that's segmented, and that has very high prognostic value as well. Here's a tool that measures liver fat quantification, which also is valuable information. So we can use this data, this incidental data, again, regardless of why the scan was performed, to really look for a lot of silent diseases and do this in a more objective, quantitative way. Things like osteoporosis, cardiovascular disease, diffuse liver diseases, as we've discussed, fatty liver, even cirrhosis, and so on and so forth. Diabetes and metabolic syndrome is a worldwide public health issue as well. Now, we've applied all of these tools to a healthy screening population. Specifically, this was a group of nearly 10,000 patients that underwent a screening exam for colorectal cancer, specifically virtual colonoscopy. But it really doesn't matter what the indication is. We can use 10,000 patients being scanned for another indication and try to look at the same value. And I'll just show you briefly, these are busy slides, but in the end, to look for cardiovascular events like heart attack, stroke, death, these simple AI tools that are fully automated, completely hands-off for the radiologist and can be displayed at the time of interpretation, outperformed the best clinical measures, which in this case would include the Framingham risk score. And so that's very encouraging that we can get this basically for nothing. And this just illustrates the same thing. We can also look at osteoporosis and the FRAX score, which is the clinical standard for predicting risk for patients. It is matched by just a single simple measure of bone mineral density on the vertebral body at L1. So when we add muscle to that, look for sarcopenia, we actually can outperform FRAX with just these simple automated measures. Let me just show you a few illustrations because I think that's a little more informative. This is a 52-year-old patient who underwent virtual colonoscopy in this series. So he's a healthy, generally healthy outpatient, no outward disease. And if he had a colonoscopy, he would have also had a normal colon, but we know on a CT scan we see more than the colon. So the images on the right illustrate not only a fatty liver on the left image, but on the right we see the patient has abundant internal or visceral fat, the unhealthy fat, and a lot of calcification ringing the aorta in front of the spine, and that also puts this patient at risk for cardiovascular complications. And so when we quantify these metabolic measures that are, again, always available on any CT scan, we can show that this data can really uncover risks that were previously unknown in this generally healthy patient. By Framingham risk score, this patient is at a very low 10-year risk for cardiovascular compromise. He's basically normal weight, just above normal. But what really happened in this patient, and was actually predicted by these measures of body composition, he had his first heart attack 3 years after that screening exam. 5 years after that, he had a stroke, and then he died prematurely at the age of 64 of cardiometabolic disease, essentially, that we should have recognized, you know, the warning signs with this basically virtual physical exam, if you will. Here's another example. This is also a healthy outpatient. This was a 59-year-old woman. Again, normal colon, but whatever the reason the scan was, it doesn't really matter. Her FRAX score was essentially normal, well below the 20% threshold where you would consider treatment for any fracture, and below the 3% threshold for a hip fracture. But when we look at the automated bone mineral density and then also the muscle density, we see this patient has advanced osteoporosis and sarcopenia. And 3 months later, unfortunately, this patient suffered a catastrophic hip fracture. Now, we didn't have time to intervene in this case, of course, and again, most of this data has gone completely ignored until now. But it's instructive to look at this patient's chart, and it turns out she had kidney stones for many years and actually had CT scans dating back to 2005. And as you go through those images, you can see the automated bone mineral density tool shows that density has been decreasing over time. And frankly, about a decade before that hip fracture, this patient was at high risk according to these measures of Hounsfield unit. So in the future, this is the kind of thing we shouldn't miss, and this patient should have been properly managed and treated many years before that hip fracture. Sometimes I'm asked, will patients actually act on this incidental data, or will their referring physicians act? And I can only tell you anecdotally that yes, absolutely, and this is my own scan. When I turned 50, I had a virtual colonoscopy. Everything was normal, except for one thing. I saw, apologies, I saw calcification, and you can see on the right image, it's segmented in red, of the coronary artery, the left main coronary artery. And I can tell you, even though I knew, as you can see from my cholesterol dating back a decade, I was running a little high, but numbers just didn't make me act. When I saw that calcification, within weeks, I was on a statin, and you can see my cholesterol is now well in the normal range. My LDL is also about a third of what it used to be. So that's good. Maybe I prevented something, maybe not, but I definitely gave myself a fighting chance. So there are a lot of other algorithms. I only touched on the basic body composition measures of fat, muscle, bone, liver, calcium, but there are many other things that we can glean from these scans because of the robust, objective nature of CT. And there are challenges that I'll acknowledge, but none of these are insurmountable, and this paper will address those. This will be coming out soon. This is a scientific expert panel that I was asked to form, and this will be coming out in our radiology journal. So in summary, CT scans are performed for a wide range of clinical indications at very high volume throughout the world. The data that I've tried to show you has generally been ignored and certainly not treated in a quantitative manner. But now with AI, we can quantitate this, and this is all automated, and we have no reason not to use this valuable data because the performance exceeds that of the best clinical predictors that we have. So I think it's a very exciting time, and I think this will add value to what we do and is really a strong example of personalized care and precision medicine. Thank you.
Thank you, Perry. Finally, we will conclude the day with a first-time live demonstration of the AI tools that we have created to take our vision of population health screening for chronic health conditions and turn it into a practical reality. I asked Dr. Orit Wimpfheimer, Vice President Strategy at Nanox and the Medical Officer, once again to the stage.
Thank you. So as we've discussed already, and as I'd like to stress, both the World Health Organization and the CDC put a big emphasis on chronic medical conditions. The number of patients getting older is increasing astronomically. We just reached 8 billion just this past week in the world in terms of population. Many of those patients are older patients. They require more imaging because they have a lot of chronic medical diseases. And where medicine has taken it at this point is really reactive to the chronic conditions. You get the patient late in the stage of their disease, and you're basically trying to play catch-up. As Dr. Pickhardt pointed out, that's really not the best way to handle medicine. And taking Dr. Pickhardt's academic vision, we're trying to make it a real reality. We want to empower the data to really extract more from the routine imaging, really identify these chronic medical conditions at a much earlier phase of their disease process, leveraging our AI tools to be able to highlight those findings for the radiologist at the time of the study, and really directing patients to the appropriate clinical pathway to really go from predictive to preventive medicine and improve patient health care. Ultimately, the patient gains the most. We're trying to treat patients earlier, we're trying to make them healthier, and we're trying to allow them to live longer with the quality of life that they deserve. The way we do that, the slide looks a little complex, but I'll walk you through it. All CT scans that are performed are automatically sent to the PACS. That's where the images live and any imaging center. What our program does is it presents an online on-premises server that anonymizes the data, so we're completely HIPAA compliant. All the patient information stays at the imaging center, whereas the images get sent to our cloud. On the cloud, the Nanox analytic agent runs our algorithms in the background, screening the population for these chronic conditions and presenting the information back to the on-premise server, reattaching the information to the patient's medical history and medical file. That information is then presented to the radiologist at the radiology workstation in one of several ways with different workflows depending on the imaging center and how they'd like to see the information. We can present it in a secondary capture format, which is the easiest workflow for radiologists. We could present it in an image to insight, which is an overlay onto the PACS. And we could also make an automatic report into the radiology reporting system, really to facilitate the use of the artificial intelligence without holding up the radiologists. Remember, radiologists are overworked, overwhelmed, and they don't need more work. But we're making it as efficient as possible so they don't need to do that much at all, and the information gets onto the report. From the radiology report, the information is presented onto the electronic medical health record so that everyone in the medical system has access to that information. The primary care physician will then have the next steps as what to do next to treat the patients for these particular conditions and how to get them the care that they need. In many places, there are also preventative healthcare units that are really focused on pulling patients out of the community for a particular health finding. There are fracture liaison services, particularly in the UK, but also throughout the world, that are focused on identifying patients with osteoporosis and pulling them out of the community to get them the care that they need. This is a wonderful tool for those types of facilities to really find patients to get them the care that they need. Everything is HIPAA compliant and medically safe. I'd like to present to you the actual algorithms that are FDA approved, our bone solution algorithm and our cardiac solution, FDA approved and already in clinical use. And I will also touch upon our liver solution, which is deep in development, but not quite FDA approved as of yet. We'll go on to a live demonstration. Here is a typical example of a PACS, where the radiologist sits in front of his or her computer and basically has a work list of all the patients that they're supposed to review during that shift. We'll just open the first case as an example. The radiologist is presented with many series while they're reading a study, typically axials, sagittals, and coronals. As one of those series, we created this automatic tool, in this case, the bone algorithm tool, to really evaluate the patient's spine. In this case, we see a patient who has a severe compression deformity in the thoracic vertebral body T9. It lists the number of the naming of each of the vertebral bodies, facilitating the use by the radiologist. They don't need to count which vertebral body we're referring to. Highlights in yellow the abnormal finding so that we see which vertebral body is abnormal and gives a % compression factor for that vertebral body. Should there be an abnormal bone mineral density, that abnormality would have been present in blue and identified as a low bone mineral density for this patient as well. We'll go on to the next case. In this next patient, this is a chest CT scan that was performed without contrast for whatever indication, whether it's COVID or pneumonia, trauma, or rib fracture. It doesn't matter. The AI algorithm works in the background and evaluates this patient for their risk for cardiovascular disease. In this case, this patient had a high degree of coronary calcium. And we present all the images for the radiologist, highlighting in yellow the segmented images of the coronary arteries where there's calcium. We present an index bar on the left-hand side that shows you where you fall into that category of the amount of calcium you have within your coronary arteries. The 0 to 100 range is a low risk for a future cardiovascular event in the next 5 years. 100 to 400 is a medium amount of calcium burden, which correlates with the medium risk for a cardiovascular event. Once you get over 400, you're in the high-risk category for a cardiovascular event. Many of these patients have no idea that they're walking time bombs. These are patients that have CT scans. The information is present on the images, and physicians don't know that it exists and are ignoring it. On the other hand, the AI tools can really find these patients, get them the clinical care that they need to be able to try to prevent that future heart attack. The last example I'm going to show you is our liver algorithm. Again, it's currently in development. It's ready for beta testing within the next month or so, but not quite yet FDA approved. Non-alcoholic steatohepatitis is a very pervasive silent disease. People are not eating quite so healthy. There's a lot of obesity throughout the world, and fatty liver disease has become pervasive. This creates a chain of metabolic abnormalities that really ultimately leads to cardiometabolic syndrome and death associated with cardiometabolic factors. These patients are walking around with fatty liver, and they just don't know that they have it. This is an automatic tool that automatically evaluates the liver on all patients who have a CT scan, giving measurements available to the radiologist at the time that they're reading, and highlighting in yellow those patients that are abnormal. If you know that you have fatty liver disease, you're going to change your lifestyle. You're going to be seeing the doctors. You're going to take the next steps of what you can to try to improve your ultimate chance for a healthier, longer quality of life. Let's go back to the slide. What's really, really interesting and really fun to watch is these algorithms in the clinical setting. This is in real data from October from an IDN in New York that ran the bone algorithm on their patients. 4,844 patients ran on this algorithm. And I'm just going to highlight the key findings. Of those 4,844 CT scans that used our algorithm, 883 of those patients had a vertebral body compression fracture. Once you've already had this compression fracture of your spine, you're in the highest risk category for an additional fracture, and you're walking around typically not even knowing you have osteoporosis. Currently, the state of medicine is that most patients find out they have osteoporosis after they have a symptomatic fracture, and by then it's very hard to roll the clock back. In this situation, you could identify patients at a much earlier phase of the disease, get them the treatment that they deserve, that they need, and try to prevent the number of patients who have hip fractures. In addition, we evaluate the bone mineral density, which adds another layer of an even earlier phase of the disease where the bone mineral density is low enough and yet there's still no fracture. And these patients also could be intervened earlier on, further decreasing their probability that they have a hip fracture later on. This is an example of a dashboard from a different IDN that has our coronary artery calcium. It's an IDN in the Midwest. This is also real data from October. In this situation, 1,779 CT scans were sent to our algorithm, chest CT scans that were performed for any reason at all. Our algorithm ran the findings on this patient, on these data set. Of these patients, 376 had a high degree of coronary calcium, and another 315 had a medium degree of coronary calcium. The vast majority of these patients have no idea. They're walking around continuing with their lives and have no idea that statins, which is a pretty simple, very, very inexpensive medication, can make a big difference in the potential morbidity and mortality associated with cardiovascular disease. We need to find these patients, we need to pull them out of the community and get them to the clinical pathway that they need in order to make a dent in the chronic medical conditions. So ultimately, I hope I showed you how we hope to superpower the data and go from predictive to preventive medicine and really positively impact patient health and ultimately also decrease the financial burden associated with treating these chronic medical conditions at a much later phase of the disease. Thank you.
Thank you for that, Orit. Now I would like to share with you a video that incorporates our vision for the future.
We will now begin the Q&A session. Our
But
first...
before the Q&A, there is one thing I'd like to emphasize. We have given you today a taste of the next 10 years. What we are, what will be the next decade for us, and what we are trying to accomplish. But the one thing that I'm so excited about is that how vision turned to reality, how Ran's vision that we actually implemented here today came to see in a real life with radiation demonstration that we have here. We built here a room, a container which is shielded, which enabled us to put inside the ARC with all the systems that are associated with, and to show you the live demo, and the live demo of all the process, of all the ecosystem that we are trying to bring to this world. And this is the one thing that I'm so excited to do a live demo, to do it in real time, and to do all the process in addition to what we said, what Dr. Shabshin actually mentioned, analyzing the first-in-human organs that have been screened earlier in the medical facility at Shamir Hospital. Now I will take the question.
Our first question comes from Ross Osborne from Cantor Fitzgerald, who is with us today.
Thanks for taking our questions and hosting us here. So I guess my first question is regarding Nanox AI. Would you just walk us through your internal process, about going after expanded indications, when you're looking at new areas of the body to try and get approved for, and then what the FDA requires?
So, as you all know, we have already FDA approvals and CE marks for all the applications that we currently provide and enable to the ideas that we work with right now. Dr. Wimpfheimer actually presented all these applications, and this is the one thing that we already have implemented and using with the IDNs and the other customers that were giving them using this applications. In addition, we have in the process, we mentioned a few of them in the earnings call that we had, and with publications that we have shared with the public. The one thing that we were talking about is the feta lever that we are finalizing these days. We talked about the future that aorta, we talked about aneurysm and a few others, and I think that also, if you have noticed what Dr. Pickhardt actually mentioned today, you can actually see what are the next in line. What we do is we analyze the application itself. We see whether the data which is available for us in the data that we currently have and all the AI tools that Michael Attias was presenting here, we can actually give a value to those IDNs or hospitals or patients and add it to the population health applications that we're providing. So more to come. The one that we have already FDAs. For a few of them, we have already CPT codes. So next.
We will now take a question from our online participants. This is from Jeffrey Cohen from Landenberg. Could you provide additional details of the physical characteristics of the ARC, such as weight, dimensions, and materials?
First of all, we have all the specs in the brochures, and more to come in the future. I think that once we start to deploy, and we'll share all the specifications of the ARC, then we're going to share it with the public as well. By the way, most of it is written in the 20F that we have provided, and the next one will be, of course, more detailed.
Jeffrey Cohen. So a CT would be the input into the Nanox AI platform. Would a ARC image enhance the image or keep it current with imaging regularly after a CT?
So we have shared in the past that part of the acquisition of Zebra Medical Imaging, which turned to be Nanox AI today, we have acquired the access to one of the largest databases of images in the world, and this actually includes the CLOUD database. We were talking about 500 million images from 30 million patient records over 10 years and various organs and applications. We said that it's coming from X-ray, MRI, CT, etc., and all of them together are the basis for the initial AI applications that we have already developed. In addition, we build the tools in order to take these images and the platform that was created at Nanox AI, and we actually are able to do synthetic data on data which is coming from the ARC, not to mention the fact that the more we deploy in the field in terms of the ARC system, then we have more data which will be collected, and hopefully within a few years, in addition to the synthetic data that we are able to simulate, we will have all these data which we'll be able to analyze and to add to the systems and the application that we are providing. In addition, we have the images that are being generated or collected or read with USARAD, hundreds of thousands of images that all of them we will be able to do what we call the data monetization as well as the interpretation of these to be added to to our database.
Okay, so unfortunately we don't have time for many more questions, so we'll take one more question from our online participants. This is from Destiny Hans. What is the timing for the liver solution? What is the pathway? Will it be a simple software update for existing customers once approved?
Orit, would you like to take it? Okay.
The liver solution, which we're so proud of, is ready for beta testing by the end of this year. So by December, we're going to have it beta tested at an IDN in the US. Get feedback from the clinicians and the hepatologists, make sure that there are no fine tuning or details we need to change. And we expect that by the middle of next year, we're going to send it off to the FDA. Currently, the product works on all CT scans with contrast and non-contrast, but there's a fine layer of tuning for additional portal venous contrast that we'd like to add. So it's still in development. It's going to be beta tested, and the expectation is to go to the FDA approximately in the middle of next year.
Thank you, Orit. So today you had the chance to witness our end-to-end solution, including what I said, a live demonstration of the Nanox ARC with full radiation, a human scan, radiology, and full demonstration of the Nanox AI solutions. I hope that you found this day to be meaningful and allowed you to better understand what we are trying to accomplish and how together we can make an impact, taking the medical imaging domain from predictive to preventive. Thank you for taking part of this special event.